All right. Good afternoon, everyone. This is Brandon Gare with the National Minority Equality Forum, and welcome to our Friday webinar. And I'm saying afternoon, hoping that, assuming that most of you are on the East Coast, but good morning, good afternoon, whatnot, wherever you're calling or visiting us from. Like I said, I'm Brandon Gare with the National Minority Equality Forum. Please want to welcome you to our webinar topic on data equity. If you were at the summit or were able to see the summit online or anything, we talked about data a lot. We have the data now. What in our first panel to set the stage was on data equity, and it was led by our very own Courtney Lang. And the reason I say our very own is because Courtney's been working with us at NMQF for quite some time. She was this year's received the Outstanding Leader Award from NMQF, and she's been working and helping us grow this organization for like I said, sometimes. So before I turn it over to Courtney, just want to make some housekeeping announcements. Please, we're going to, if you have questions that you'd like her to ask our distinguished panel that she's going to introduce, please put them in the Q&A box. And that's about it. Ashley and I will be in the background putting up notes if there's something that comes up. But other than that, please put your questions in that box. And without further ado, Courtney Lang.
Thank you, Brandon. Appreciate this platform and opportunity and the recognition and acknowledgement. Greetings and thank you, audience, for being with us on this day in celebration of data equity and advocacy. We ask for your light during this summer solstice season day. So we are opening our webinar with Advancing Data Equity, highlighting OMB's recent update to Statistical Policy Directive 15. This session recognizes the tremendous work of the Data Equity Coalition and the leadership of the National Minority Equality Forum and Blue Cross Blue Shield Association. Our panelists will be presenting in the following order: Gretchen Wortman, Juliana Zhao with the Center for Law and Social Policy, Karen Howard, Mental Health America, Denise Schofield, Blue Cross Blue Shield Association. Two of our panelists have also written issue briefs on data equity following the March 28th, 2024 update that OMB released, expanding the categories for race and ethnicity. With that expansion, we are pleased, we are hopeful, but we also recognize that we have more advocacy work to do. The unique aspect of the Data Equity Coalition that you will see is that we actually welcome and value diverse perspectives as it relates to race, ethnicity, language, sexual orientation, and gender identification. We recognize the different pathways, but we come together with a uniform voice in appreciation for data standards, and we are advancing that as a part of our coalition activities. So Gretchen, before I turn the floor over to you as the first speaker, I'm actually going to cue our title slide so that the audience can see that we are grounded in our work around advancing data equity. And then we are moving to the next seamlessly. And by way of introduction, yes, Courtney Lang, and then our Data Equity Coalition QR code. Please take a moment, click on the QR code, and it will land you to the Data Equity Coalition website, where you can download the issue briefs that are being highlighted today by the Center for Law and Social Policy and Mental Health America, our Data Equity Coalition partners. So with that, and without further ado, Gretchen Wortman, the floor is yours.
Thank you, Courtney. Good afternoon. My name is Gretchen Wortman. I am Vice President for Policy and Program of the National Minority Equality Forum. And in that role, I direct our Institute for Equity in Health Policy and Practice and our National Alliance for Brain Health and Awareness. I'm keeping my comments brief, I hope, to afford maximum time to my other panelists and to the audience to hopefully enable opportunity for constructive engagement with this panel. I would like to, on behalf of the National Minority Equality Forum, thank Blue Cross Blue Shield Association for their leadership in enabling this essential collaboration. And most importantly, I want to mention my colleague, Ms. Keisha Brooks-Colley, who is Vice President for Advocacy for Blue Cross Blue Shield Association. And this is heartfelt. Her focus and her guidance have been key and continue to be key in the success of our coalition. So she can't join us today, but I want to make it very clear that she is here. She's always here in the background. The National Minority Equality Forum would also like to thank Courtney Lang for her management and facilitation expertise. Brandon noted it briefly, but the longer I work with Courtney, the more I value and understand what it takes to continue to move these kinds of initiatives forward. So thank you, Courtney.
Yeah.
And most importantly, I want to thank the organizations that have joined and lend their support to the Data Equity Coalition. They are indeed the coalition, and their ability and willingness to engage have made this possible. As I transition to my colleagues, I do want to offer the following, and I'm going to try to read it so that I don't skip anything. Inequities in access to the creation of evidence that drives health services research delivery and financing compromise the ability of our system, of our country, to provide an experience with the healthcare system that offers value and quality for all population cohorts. And I'm stating this for a purpose because there tends to be a perception that somehow an equity conversation is associated with populations who have historically been minoritized in our country. Failure to design and implement and monitor the impact of a system that assigns equal value to all population cohorts in the final analysis compromises the experience of all population cohorts. The Data Equity Coalition and the work we're doing is an essential response to historic inequities in our country, and we ask you to join with us and to support us as we move forward. And so I guess in short, I would say that context, opportunity, and intentionality are key. Thank you, Courtney, and I turn the mic back to you.
Thank you so much, Gretchen. And for visibility for our audience, we have shown on the screen our coalition members that Gretchen acknowledged, and we appreciate Gretchen's leadership in this effort. It has been a longstanding commitment, both by Gretchen and Dr. Puckrin, to make sure that data was elevated and that representation and improving standards for data where individuals can see themselves in the improvement of our therapeutic charge to address disease, treatment, access, and care. So with that, I will now transition over to Juliana Zhao, who is our policy analyst. She is representing the Center for Law and Social Policy. Juliana, thank you so much for your leadership with the issue brief, and the floor is yours.
Great, thank you so much, Courtney. As Courtney just mentioned, I am a policy analyst with the Center for Law and Social Policy's Public Benefits Justice team. So I primarily work on issues relating to Medicaid and immigrant access to benefits, and I have colleagues that work on a number of other public benefit programs. As an anti-poverty organization, we know and we see throughout our work that every additional layer of marginalized identity can increase an individual's likelihood of poverty. Next slide, please. So, our main focus in supporting the call for data equity through the Data Equity Coalition is this notion that without data, you can't see the cracks that are starting to form within a program or within a system. And data illuminates the intersectional causes of inequity. And you really need data to be able to tell when marginalized groups are being disproportionately affected by negative outcomes every time policy changes. I know that intersectionality is quite a commonly used term, but I have really never found a better definition for it than the originator, Kimberly Crenshaw herself, from her 1989 paper on demarginalizing the intersection of race and sex, which is this idea that intersectionality is a metaphor for understanding the ways that multiple forms of inequality or disadvantage sometimes compound themselves and create obstacles that are not understood among conventional ways of thinking. In the work that I do, working on issues relating to Medicaid and immigrant access to benefits, I often have to exist at that intersection and think about the ways in which immigrant groups might not be reached by a particular policy because of their status, or I might be thinking about the ways in which certain Medicaid policy changes how it will be implemented for people with disabilities, or the ways in which new state proposed changes to policy might be more difficult to access for people of color or people who exist in other marginalized identities. It's really this idea of standing at the intersection of 6 different streets can be a lot more dangerous and a lot more detrimental to your health than standing at the intersection of 2 streets. You know, just every additional layer of an identity that society has chosen to marginalize can increase your risk. So in my work, particularly, I have seen this with the Medicaid unwinding process over the last the last year or year more. For those who aren't familiar with the ins and outs of Medicaid policy, from March 2020 until March 2023, people who are enrolled in Medicaid had uninterrupted coverage, thanks to a continuous coverage provision that was part of the federal COVID-19 response. And then on April 1st, 2023, states began to check everyone's eligibility and disenroll those that they found to be ineligible. And you can see from this chart early on, before the process began, a lot of advocates were predicting that millions of people were going to lose coverage. And based on trends in coverage loss from previous years before the pandemic, advocates predicted that being disenrolled despite still being eligible for any number of administrative reasons were most likely to happen to Latino individuals and Black non-Latino individuals, particularly children. And so this is just what the anticipation was going into the process. Next slide, please. Once the process began, we saw that very few states were reporting Medicaid disenrollment data by race and ethnicity, and it was only by choice. There was no federal mandate to do so. And although the federal government tried to, step in where procedural disenrollment seemed to be particularly high, it was very difficult for advocates on the ground to understand what was happening to marginalized populations when Medicaid disenrollment began happening. Now we know, 2 years on to a year plus on, that as at least 23 million Medicaid enrollees have been disenrolled, disproportionately affecting children of color. And in many states, as much as 93% of the disenrollments were due to procedural reasons, meaning not because people were no longer ineligible, but because they didn't respond to requests for information, or the mail was going to the wrong address, or they were unable to complete their renewal forms for any number of administrative reasons. We also know, as advocates on the ground and speaking to our partners, that immigrants, people with limited English proficiency, those with disabilities, and older adults also faced a lot of barriers to Medicaid renewal and were at increased risk of losing Medicaid coverage. So that's just the most like salient example that I encountered in my work. And I think a really key example of how race and ethnicity data equity is key to health equity across the country. We were just as excited as the rest of the Data Equity Coalition when the federal SPD 15 data standards were updated. However, we agree that a lot more work could be done in terms of encouraging states to take up that update and to be more transparent generally about providing race and ethnicity data breakdowns for all types of public data sets. As an organization that works on anti-poverty policies, much of the data that we rely on to do our work are public data sets, be they federal or state or local. And so when those data sets aren't broken out by demographic characteristics that we know just from working with affected populations, are more likely to be correlated with higher rates of poverty, higher rates of marginalization, greater barriers to access, it becomes very hard to show lawmakers this is why you need to care, because people are being negatively impacted. And I have many more examples that I'll continue to share throughout the webinar today, but I thank everyone for their time.
Thank you, Juliana. And while you have the floor, I was hoping just to ask the question, if you could explain why intersectionality is so important to the work that CLASP does as it relates to both REL and SOGI populations. You touched on it, but not everyone is familiar with the intersectional nature of how data sets are collected. So I was hoping that you might be able to just address that just for a moment.
Yeah, of course. So REL, race, ethnicity, language, and SOGI, sexual orientation and gender identity, are two like categories of like demographic characteristics that the Data Equity Coalition has been really pushing for like stronger standards on. And I certainly have a number of ways in which it's more difficult to understand the needs of individuals who belong to marginalized race or ethnicity groups, or have limited English proficiency, as I mentioned, or have other communication or language needs if they belong to the disability community, for example. But there is one resource I can share. That I'll share to the chat in a minute, but from our partners at the National Immigrant Law Center, they put out a report in 2023. We know that individuals with limited English proficiency who receive home health care are more likely to be readmitted to the hospital than those who speak English very well. And to compound that with another level of marginalization, age, children with parents who have limited English proficiency are twice as likely to experience adverse medical events when they're hospitalized, potentially due to language barriers in communicating with their doctors. So not only are children having to communicate to their caretakers what's wrong with their body, where it's hurting, but then the caretakers with limited English proficiency then have to relay that information to doctors in a language that is not their primary language. So these are just some examples why it's important to collect information about people who belong to like marginalized REL or SOGI population, because without that information, we cannot know what aspects of our systems need to be changed in order to better support the health and well-being of these populations. From a poverty perspective, we also know that transgender individuals and bisexual cisgender women specifically have the highest rates of poverty, 29.4%, I believe, as of 2019, which is the most recent data. So that's another example.
No, the super important examples, and I'm delighted that you raised the limited English proficiency. That's an area of work that we're going to continue to obviously amplify and advocate the importance of the work. And you also nodded to disability. And so because of that, I want to make sure that we introduce our next panelist, Karen Howard with Mental Health America. And that would be the next slide, Ashley. Perfect. Thank you. Is going to give us an overview of the work that she has been participating in as it relates to the youth mental health movement, as well as disability. Without further ado, Karen, thank you so much for being with us today.
Thank you so much, everyone. As Courtney stated, I'm Karen Howard. My pronouns are she, her, and I work with Mental Health America, a consumer-based advocacy organization. And we're really interested in the intersection between equity and disparities and youth mental health, and ensuring kind of standard data standards for race, ethnicity, language, sexual orientation and gender identity, as well as disability. We thought this was really important to highlight in our brief because mental health challenges are the leading cause of disability and death among young people. MHA's screening program sees 15,000 people per day taking an online screening, and 40% of those are under age 18 years old. There are access barriers, which we're all very familiar with, that help contribute to this kind of youth mental health crisis, including the behavioral health workforce shortages, a lack of a specialized, culturally and linguistically responsive workforce, lack of infrastructure for young people and their families to connect, limitations on insurance coverage, which Juliana just discussed, unequal treatment of mental health services and payment and cost sharing, and other barriers that relate to social drivers of health and needs that marginalized communities have. Addressing these factors through policy is necessary, but of course we need data to really try to drive policy changes. So I wanted to share some of the data from our brief, and we talk about this in the next slide. Overall, the youth mental health crisis is measured through several data sets, including MHA screening data, the CDC data. But here in our brief, we start off with SAMHSA's NSDA survey, which is an annual survey provided to the general population in the US. And they released a trends document, and from 2000, in the decade 2009 to 2019, the percentage of youth ages 12 to 17 that experienced a major depressive episode in the past year had nearly doubled. And furthermore, the national suicide rate among youth and young adults increased 57% from 2007 to 2018. So there's just overall high prevalence of youth mental health challenges. When we look at some of this data by race or ethnicity, we come up with some different storylines and narratives that aren't necessarily displayed when or understood in general overall data. So we encourage in our brief to disaggregate data by race and ethnicity to reveal some of the disparities in prevalence and access to care. For instance, the percentage in that NSDA study for all youth experiencing a major depressive episode increased 7.6% in that 10-year decade, 2009 to 2017. However, for Hispanic or Latino youth, there was an increase almost 3% higher of Hispanic youth experienced a major depressive episode. Additionally, these same youth have lower access to care or experience more challenges to getting treatment. So non-Hispanic youth who received treatment for major depressive disorder in that 10-year period increased more than 10%. However, the increase in Hispanic youth in particular was just 4%. So the increases in access to care or utilization of care are lower in certain ethnicities. And with respect to Black youth, overall annual percentages of children with any outpatient mental health care in a study by Ulfson that was published initially in the Journal of Adolescent Mental Health and Psychiatry, they showed about 12% of children had any outpatient care, and in 2019 and in 2021, just 2 years later, that number just jumped to 13%. So there was very little change or in how many young people, how many children were accessing outpatient care. However, when we disaggregate by race, the authors of that study found that Black youth actually decreased their outpatient use of mental health care in 2019. It went from 9% in 2019 to 4% in 2021, so almost half of utilization. And for white youth, it increased from 15% to 18%. So that showed an increasing gap that overall outpatient mental health care in children numbers just did not show. With respect to suicide rates, wanted to just share that overall suicide rates declined below peak in 2018 for youth and young adults ages 10 to 24. However, disaggregating by race and ethnicity showed a significant increase in suicide rates among Black youth and young adults from 8 to 11 out of 100,000 people. According to CDC, 16% of high school students who identified as American Indian or Alaska Native, and more than 14% who identified as Black reported attempting suicide. However, those numbers are higher than the overall 10% of youth experiencing suicidality. I don't want to do too, I guess, many stats and stuff, so let me just break.
No, we appreciate the statistics. It helps to ground the conversation. Karen, you have been on the front line of the advocacy movement for mental health care, and was hoping that you might be able just to share why advocacy needs data equity in mental health in order to help to prevent the crisis of the youth mental health prevalence that we are facing in the U.S.
Sure. So as you saw in some of the data by race and ethnicity, without a standard way to collect and kind of a requirement to collect some of this race and ethnicity data, it's really hard to tell your story and paint the picture of the need. And critics or people who are not in favor of this idea that there are communities that experience higher levels of barriers and problems to care, they say, well, the data doesn't show that, or there's no report that says that, so you're making this up. And so in order to help ensure that critics are able to see facts and understand what the truth in numbers is saying at a population health level, it's important to have this data collected federally and in the states and throughout practices and settings.
Thank you so much. I think that's a great hashtag, truth in numbers. Truth in numbers. Thank you, Karen. We are going to turn over to Denise Schofield, who's actually going to give us an overview of what's next now that the Office of Management and Budget has updated SPD 15. Denise, if you could take us through what we need to be focusing our attention on for the future. We got the update, but we're clearly not done with the work. Denise Schofield, the floor is yours.
Thank you, Courtney. And thanks to everyone here on the panel. The information provided on what these impacts are to individuals is critically important to continuing the advocacy and the work that needs to be done beyond what has already been achieved. So just by way of background, my name is Denise Schofield. I work for Blue Cross Blue Shield Association. I work very closely with Keisha Brooks Coley on these data equity coalition efforts. And not to understate the importance of SPD 15 and what happened earlier this year, but as Courtney said, it really is just a first step in the journey that we are taking to create data equity. The updated standards will give us an opportunity to improve data accuracy and reliability over time. It does enable broader inclusion of historically marginalized populations and communities. And it gives us an opportunity to use that information to create more effective and equitable access to healthcare interventions for those marginalized populations, as well as tracking what the emerging disparities or inequities look like within these populations. Very significant. This is the first time in nearly 30 years that the standards have been updated, in almost 50 years since they were first put into place. And in that time frame, the changes in demographics within the United States have really evolved, but those standards didn't evolve with them. So we're closer now with the race and ethnicity categories, particularly with the addition of the MENA category and the ability to disaggregate the information. You heard a couple of examples from both Juliana and Karen on how disaggregation of data is so important. Aggregating data washes away some of what we need to look at in order to address inequities. But again, it's the first step. We were very pleased with the update that came in April of this year, but it didn't include everything that's important to creating data equity. So for example, OMB did not address sexual orientation and gender identity. Language was not addressed, not within their jurisdiction. So what we need to do now is focus our advocacy on what is happening over the next 18 months as the different agencies create their action plans for implementing these new standards. So there's still an opportunity for us to, as a coalition, as organizations, to continue to advocate for what's important to data equity. In terms of next steps, and we're working very closely with NMQF and the coalition and HHS to continue to raise the importance of this issue, not just with HHS, but with Congress and with the administration. We've already issued some recommendations to HHS to ensure that as the action plans are created, they're done effectively, they're done efficiently, and they incorporate all of the minimum requirements, not just for the federal agencies, but really we're looking for mandatory, non-voluntary implementation of the standards. That was one area in the OMB policy that was not updated. So we're hoping to continue to advocate for mandatory implementation of these standards. And we really want to build on the momentum of the new policy to incorporate SOGI, sexual orientation and gender identity, because that was not touched by what the SPD 15 update was defined by. So we've already communicated what you see here on this slide to HHS, and we'll continue to work closely. We'll pivot to additional advocacy efforts with HHS as work groups are put together and as those action plans are being created. We are going to be at the table representing the interests of the coalition to ensure that the progress that we've made so far doesn't stop here. So I'll pause there, Courtney, and see if there are any questions.
Well, I definitely have one question for you. As you alluded to in your remarks, Denise, you spoke to this 18-month horizon that we find ourselves in, which began actually on March 28th. And given that it took 30 years for the update to occur, what can we do within the next 18 months to help to ensure enforcement, accountability, and understanding of why that 18-month period with federal agencies is so important?
It's a great question, Courtney. I think it's critically important in this 18-month phase to continue to keep the issue at the forefront of the individuals who are accountable for implementing these standards. Being able to articulate what the impact is to these historically marginalized communities, similar to the examples again that Juliana and Karen gave, is really important to ensure that those who are responsible for implementation understand why it's so important. We're talking about people and individuals, not simply categories of race or ethnicity. So I think important in this 18 months to keep the issue top of mind, to work together collectively as organizations to continue to advocate for those changes that we know need to happen, that didn't come through this first update to SPD 15, and really build on the momentum. And again, providing that context, that impact, the stats, the data, it's critical to ensuring that this issue stays top of mind for those who can help shape it.
Thank you so much, Denise. And Ashley, I believe you have a QR code. We're going to hold this QR code on the screen for a moment once again to direct your attention to the Data Equity Coalition website before we take questions for the panel. We want to make sure that you can scan the QR code, go to the website, and download the issue briefs that are highlighted, the issue briefs that Center for Law and Social Policy, Mental Health America, Black Women's Health Imperative, American Heart Association, and the National LGBTQ Task Force produced following the update to OMB's SPD 15. Thanks so much, Ashley, and we can go into gallery mode. Thank you so much. We are open for questions for the panel, and I have one that I want to start off with for Gretchen. Gretchen, you were really eloquent in your setting the foundational stage for our time together on this educational session, but wanted to circle back to ask, why is data equity so important to the broader health equity movement, and making sure that we can connect the dots for the work that we're doing to advance health equity holistically, and really the work that we're doing granularly with advancing data?
Thanks for that simple question, as usual.
You're welcome.
Courtney. I think my answer would be that data equity needs to be understood as the conversation that we're having in the United States and by extension globally regarding assuring the health of all populations. All information in some way, whether it's on biomarkers of race, ethnicity, language, SOGI status, is not only information, but it needs to be accessible and analyzed as data that is, or sort of absent which, compromises the ability of the system to identify the pressure points, to monitor activity and identify the pressure points in this compound complex systems loop that we call the healthcare system. So I would say the importance of data equity to the health equity movement, moving upstream from that is the essential nature of having data that's collected in a way that is standardized and is applicable to all populations to inform health services research, delivery, and financing. It's not just the health equity movement, it is the sort of structured system of engagement that enables our technology to be responsive to all of the different population cohorts. That's a maybe broader answer than you had in mind, but I think it's also important that everyone understands the essential nature of this conversation. Denise spoke to making sort of the OMB activity more visible. I would submit that it's not making it more visible. It's part of the challenge is making Americans aware that these conversations exist, that there are rules and regulations that govern how their information is collected and analyzed. And in a very real sense, it's how you have an ability to vote within the context of healthcare. So that may be a longer answer than you wanted, but thank you for asking.
No, I think that's so important, because we want to make sure that each of the advocates that shows up on this call or listens to this webinar understands that the moment that we are talking about health equity, we are also talking about data equity. And we need to be intentional about that so that we're not leaving anyone behind and that everyone is seen and represented. Karen, Juliana, you produced issue briefs on behalf of your organizations. And in those issue briefs, that we had the QR code so that the audience could download, in those issue briefs, you advanced some recommendations that you wanted advocates to better understand and socialize. So Karen, I'm going to start with you and then go to Juliana. Can you give us a highlight? What is the recommendation that Mental Health America made in your issue brief on youth mental health?
We recommend that data is collected about race, ethnicity, language, sexual orientation, gender identity, and disability status to help paint the picture of the need and then build the systems that will help to both prevent and intervene early in childhood, that are sure to improve accessibility of services and not continue to kind of shut certain families and children out of our kind of mental health care system. We didn't outright say this in the brief, but we'd love to see more Medicaid and CHIP services built in schools, and some of that outcomes from that data shared so that we can evaluate effectiveness and, you know, who's really served. But we know that serving young people in school settings is really effective.
Thank you so much. Juliana, class, what is the pearl of recommendation that you advance in your issue brief?
Yeah, as an organization, we believe really strongly that any data analyzing or data processing that happens should be done in concert and in collaboration with the community of interest. So I would say our key recommendation from the brief is that researchers, government agencies, healthcare stakeholders should partner with trusted community organizations to center the experiences and perspectives of groups who face negative health outcomes when trying to understand how to address these disparities. You know, oftentimes it's unclear what the cause of a particular health disparity trend might be. And so to try and solve the problem without going to the people most directly affected and asking, like, why are you, experiencing a higher rate of kidney disease or, lung cancer? It's foolhardy.
That is very important work that class does from a research lens as well. And one of the questions that was submitted into the Q&A for this call is speaking a little bit more about research and wanting to better understand how private sector stakeholders are impacted by the SPD update. So Denise, I'm going to turn that question over to you. How is the private sector impacted by OMB's update on race and ethnicity?
Actually, one of the items that we advocated for was to have the standards apply to the private sector as well. And that did not come through in the guidance that was given earlier this year. Speaking from a Blue Cross Blue Shield perspective, though, our commitment is to continue to advocate for the standards around language, SOGI, and to comply with the standards that have been issued by OMB for the updated SPD 15. I think it's important that from a private sector perspective that we ensure interoperability of the data. And so it's important that we also adhere to the standards that have been promulgated by OMB. And so we'll continue to do the work as an organization. An organization of 32 locally owned and operated plans are very committed to the work of data equity. But we're hoping that in this next 18 months, we can continue to advocate for non-voluntary adoption of those standards by the private sector.
If I could
Yes, absolutely.
add to that, Courtney.
Yeah.
I think what's also important to remember is that the fact that the OMB 15 update did not mandate that sort of non-voluntary compliance, does not prohibit it. And so it's a starting point. And all of the speakers here have through their lenses spoken to the need to increase awareness at the federal, state, and community levels of the fact that this information needs to be collected and integrated into decision-making in the different forms with which we engage. And so I just wanted to remind folks, it's not a maximum.
Right.
OMB is a minimum. OMB is a minimum for other federal agencies. And so what we're looking at as through the Data Equity Coalition is to continue to engage with the federal agencies to sensitize them to the need to expand their data collection beyond the OMB minimums. Thank you.
No, super important information. The minimum, it's the minimum that was advanced, not the maximum. It's a great point, Gretchen. One of the questions that came into the chat was how long do you anticipate that it will take for OMB guidance to be implemented completely, holistically, and the needed data to be available to sort of realize this minimum threshold that was established in March? Denise, you want to take that and then we can open it up?
Yeah, and Courtney certainly jump in as well. The implementation date for the new standards, I believe, is in 2029.
That's right.
So it is a fair ways out. Anything new that's developed has to adhere to the minimum standards. But we're trying to, and we're hoping that the implementation goes faster. than 2029, because that is a fair ways out. I think that's balanced with understanding sort of what needs to happen from an operational perspective with these agencies and organizations. So to the extent that we can also advocate for some support around the technical portions of the implementation, I think that will also help, hopefully, to advance the implementation prior to that 2029 date.
Karen, Juliana, thank you, Denise. Chronic disease communities want to know how they can incorporate data equity, the SPD 15, into their advocacy work for access to care, for therapeutic concordance, for ability to advance greater education and policy awareness about their respective chronic disease focus, be it neuroscience, oncology, hematology. So are there some recommendations that you have, since you've been immersed in the work, on how they can help to socialize their stakeholders on this important issue?
Sure, I can just say that the National Health Law Program put out a really good report on the overall efforts of the disability advocacy community and how many of the people with disabilities who are experiencing disparities in healthcare outcomes, there's not enough data to show whether or not their disability contributes to those outcomes, or if those outcomes are due to other factors, and people may be living with certain chronic conditions that also are not related to their disability. And so I think in your conversations, making the connection between the intersectionality that we've been talking about, that individuals, whether children or adults, they're dealing with they may be dealing with multiple layers of experiences that can together through data be identified and studied, so that systems, whether it's electronic health records or other data collection methods, like Medicaid and states have to submit data to the MSIS system, the TMSIS, that national researchers collect data through. And so we appreciate your advocacy and interest in partnering, and also would be happy to further kind of have discussions about particular talking points you can use.
That's a great point. We need to socialize some broader talking points on this subject. So I think that's a great takeaway from this webinar and educational session. Juliana, the social justice community put in the chat a very similar question. How do you socialize for justice advocates the need to prioritize the data equity aspect in healthcare?
I think oftentimes people most affected by data equity issues in healthcare, they very well understand that theirs is a data equity issue. You know, when the Native Hawaiian Pacific Islander population saw massive mortality rates among their populations and knew that there was no like NHPI race and ethnicity data from states showing just how bad it was, they had to build their own data platform. CLASP worked with a patient advocacy organization on a brief addressing how the barriers and the hurdles for people with long COVID to access certain public benefits like TANF, the Temporary Assistance for Needy Families, and SNAP, Supplemental Nutrition Assistance Program. And in those briefs, we did a lot of qualitative studies, talking to people with long COVID, fighting for recognition of their disability in order to access these benefits. And many times they were able to identify that it was harder to get providers to believe their symptoms if they were women or people of color or had other marginalized identities. And so I think a large part of it is working with patient advocacy organizations and keeping a broad view. When you're thinking about, when you close your eyes and you think about who the affected patient is, also keep in mind all the overlapping layers of identity that can compound the difficulties in access.
I love that. Overlapping layers of identity. We've had some great phrases that help to encapsulate this conversation, this dialogue. We are all patients at one end of the spectrum or another. You were born into this world as a patient of the healthcare system and most likely will exit as one. I frequently say that the data always matters, and we want you to be seen so that the best care can be delivered for you. This is about solutions to the problem. Final thoughts, panelists, just quickly, round robin, just 10, 15 seconds. Gretchen, I'm going to turn it over to you. Final thought.
Thank you for staying with us. The National Minority Quality Forum continues to be committed to assuring that we create a health services research delivery and financing system that assigns value to all, oh, I love it, overlapping layers of identity.
Thank you.
We're small. I'm going to take a little more time. We're small, but I would say the message from everyone here is that we have to operate simultaneously at the federal, state, and community levels and engage actors who have agency that they may not yet recognize to bring about this change. So thank you.
I love that they may not yet recognize. Denise?
I would just say in closing, Courtney, that as energized as we were by the SPD 15 update, we've been more energized by the work ahead of us, understanding that we've made a difference and we will continue to make a difference through our advocacy. Because at the end of the day, these are people, families, communities that are impacted by a lack of data equity. And it's in our DNA, it's in our mission to ensure the health and well-being of all Americans. So we're looking forward to continuing this work and to advocating for what is right.
I want to also acknowledge the papers that were produced. Juliana Zhao, Center for Law and Social Policy, Karen Howard, Mental Health America. Please download their issue briefs. Special thank you to Dr. Gary Puckrin, President and CEO of National Minority Quality Forum. Special thank you to Kim Keck, President and CEO of Blue Cross Blue Shield Association, and special thank you to each one of you. You represent voices that would otherwise be voiceless, and for that, we owe you a debt of gratitude. Join with us in this movement. Join the Data Equity Coalition. We need you to continue to advance the mission so that race, ethnicity, language, sexual orientation, and gender identification are prioritized across our healthcare ecosystem. And with that, we thank you so much. Be well.
Thank you. Bye-bye.
Thank you.